She will be talking about manage pediatric cochlear implant damage. So this topic is very interesting for every doctor here because this clinic often we meet some children have implant cochlear damage and how to manage and how to announce the result for surgery for this patient. So thank you for your presentation.
Thank you, Professor Good afternoon, everyone. Today I'm very happy to be here to have my presentations about management of pediatric cochlear implant damage. First of all, I think everyone here know about the implant damage. Sometimes we can see it's a clinic. So what is a implant damage? That's epidurable damage is benign tumor, not malign, considered in the most common congenital tumor affecting the eyes. And liver damage is found in 10 to 29% of pathological lesion of the livers. Congenital overground abnormal tissue by collagenous connective tissue covered by epidermoid epithelium in an abnormal location. It presents as a single or multi-lesions, generally located in the inferotemporal globe or temporal lobes. It's along or associated with systemic conditions like preauricular gas, papillocoloboma, and the other syndrome like golden heart or francisectomy. Here are the pictures of two persons. One, a person in a foreign country is a place of golden heart syndrome. You can see here, and here is a Vietnamese patient, my patient. I have just seen him saw him yesterday with abnormal of the ear, a big tumor in the right eyes. And actually, he can close the paratype. About the pathogenesis, now it's not clear. The liver damage is thought to arise from an early embryological anomaly occurring at 5 to 10 weeks gestation, or resulting in metaplastic transformation of the mesoblast between the rim of the optic nerve and sulfate ectoderm. About histopathology, the liver damage shows hair follicle, facial gland acini, or discreted elevated nodule of the fibroconnective tissue. Genetic and inheritance, the pattern of inheritance is quite variable in epidurable choriotoma. They can be autosomal dominant, recessive, or X-linked, or multifactorial, etc. About clinical features. In these images, you can see is a tumor in the lymph node of the eyes. The tissue look like the skin, a normal skin, with some seal, a fine seal here, and it can be a solid tumor with a smooth or dry surface, or often with a fine hair. Consistency hard, sometimes rubbery or soft. The normally is rubbery like the skin. The color whitish, yellowish, or pinkish, depending on race of the human. The size from a flat lesion of a few millimeters to large, mass filling most of the epidurable region. and it's developed very slowly with the growth of the eyeball. The astigmatism is often present and it harms to the acuity visual of the patient. The classification is very important with the lymphodenoid because it can help us to find out how to treat the tumor. Anatomically classified into 3 grades for men, grade 1, 2, and 3. Grade 1 lesion is less than 5 mm localized to the limbus. Grade 2 larger lesion covering most of the cornea, extending deep into the trauma down to the cement membrane without involving it. And grade 3, it is the least common, with the tumor very large, covering the whole the cornea, extending to the histological structures between the anterior surface of the eyeball and the pigmented epithelium of the iris. Here are some pictures about the grade 1. The tumor is under 5 mm and located in the limbo, not too high, not too deep. The grade 2, the tumor is bigger than 5 mm, but it's extended into the trauma only down to the descending membrane without involving it. And the last one is the grade 3. Grade 3 is almost the globe is a tumor. You can see it's the pictures in the book. And my patient, she had 2 years with tumor in the fourth eye, very severe. About the management, is the main thing I want to talk today. The management include medical management and surgery management. And some senior, when we follow up the patient, we have to change from the medical management to the surgery if it damages to the function of the eye of the patient. But the medical management indications, almost for grade 1, they will eat with a very small intake of diameter in height, normally smaller than 1 mm, and mild astigmatism, less 1, deal with minimum surface irregularity, and good compliance with spectaculation. And with this tumor, the best thing is leave the lesion alone, because the acuity is still good, and the patients feel uncomfortable with this. And if the patient can follow up very well. Because if we cut it, a simple cut, it can lead to scarring and develop a visual operation, and it's very bad with this. And the examination we have to do with this rate is one every 2 or 3 months. We need to check visual acuity stereo, the presence or absence of amblyopia, cycloplegic refraction, gonioscopy too, and sign of the lesion, spectaculation and amblyopia treatment if necessary. The examination should continue unless the patients meet the following criteria for surgical intervention, like develop of clinically significant anisometropia, presence of amblyopia is impending or established, lack of compliance with either follow-up or spectaculation is recognized, and growth of the lymphodenoid induced marginal gland, resulting in surface disease and increasing anisometropic astigmatism. is about the domestic consideration too. Surgical management, indications, grade 1, but that affect the function and as domestic of the eyes is very important. And of course, always surgical management with grade 2 and grade 3. Indication for primary surgical interventions in grade 1 lymphedema. Chronic eye rubbing due to irritation and recurrent conjunctivitis. Recurrent infection. Amblyopia responsive to medical management is very important. Progressive delay with corneal sulfate decompression and growth and encroaching into pupillary area or optic zone. Domestic consideration, induction of the irregular astigmatism and in the quarterly closure. But the technique of surgical is very insensitivity, like a simple excision, lamellar or penetrating keratoplasty, AMT, ALSCA, autologous liver stem cell allograft. That depend on the rate of the lesion, the deep the size and size of such lesions. It's a top. We can see a top what the recommendations for surgical removal of ocular damage. It depends on the rate of pediatric liver. Recommend technique, like here. With grade 1, very small, less 1 millimeter diameter, and the deep under 15 micron. The thickness, we can simple excision, but very rare because sometimes it can recurrence with the personal derision. Grade 1, a little bigger, deeper, less 100 micron, and smaller than 1 millimeter diameter. We can do keratectomy with AMT and ALSCA. Sometimes AMT multi-layer is good too. Grade 2 and deeper grade 1, keratectomy with AMT, LSCA, PPG, basal anterior or deep anterior lamellar keratoplasty. And with grade 3 is the most difficult to do because we have to perform many techniques together to make the reconstructions in the lobe. Management post-operations, we have to check visual acuity, automatic refraction of the patient, intraocular pressure, treatment amblyopia if necessary, include patching and glasses, with patient glasses, and medication post-op like antibiotic, corticoid, artificial tear. Have to follow up the complication post-op like infection, personal derision, graft resection, etc. Here is one case I want to show you as my patient with the tumor in the left eye. The rate of tumor is grade 2 with 6.5 millimeter. She is a female, 30 years old. When we come with her, she is very depressed with her face, with that tumor. She always feels unconfident and very sad about this because she's a girl and now she grow up. The system, she feel irritations with the left eye. They sometimes have itching and tearing. The size of tumor is about 6 mm, and see clearly when I open and close. It's quite difficult to. We can see them clearly when she closes the eyes. The refractions of the right eyes is 25 and 0. 149 degree, and in the left eye we can undefined Visual acuity in the right eyes is 20/70-week glasses is 20/25, and in the left eye it is 20/30. And we do DLAK for deep anterior lamellar keratoplasty for with a pre-cut of the with a graft is from a pre-cut, and it's a pictures post of 7 months, and the graft is clear and still have 1, 2, and 3 sutures here, and reflection is on the left of the right eyes is like this. And the vision acuity with glass is good in 2 eyes. The right eye is 20/25 and the left eye 20/30 with glasses. And if the patient's face after post surgery 7 months, the patient feel more confident and feel comfortable with the glasses. And another case, a male 7 years old, is the first features is when he come with us, he was 7 years old, and post DLAK, post 2 years later, if you the graph is clear and the vision pre-operation and post-operations is good, 20/25. Another case, after 2 years with DLAK treatment, the rat is clear too, and his vision is 20/30 with the right eyes. This picture of his eye is good. Page 4 is quite expired with the tumor in the both eye. She's have the problem with the tumor in the both eye, and she's after 2 years we do keratoplasty for her. The graph is quite clear, not the vision is not good like the boys before, but it's okay. This is a boy with a very big tumor. He's a new patient, but the problem is epidemic. He have a lot of fat go into the globe. Yeah, it's very big. When we do operation for her, we have to cut. It's a very big tumor, and the graft is 10 diameter. Another case with the tumor, a lot of fat. And this is a case have pathologium post simple cut, simple. And he was cut the tumor when he was young, very young, 10 years ago, and he come with us about 25 years old, and his vision is good, 20/25, and he don't want to operation, so we just follow up him and ask him come back when he want to remove it, but I think it's very difficult. We can cut it and use AMT multi-layer to treat him, but to prevent pathologium, maybe we have to use mitomycin C with the collusion. Lymphodepletion can affect the vision by including astigmatism leading to amblyopia in children. About the domestic reason is very important too. Follow up the aggressive amblyopia treatment. Patching glasses, tuning by a method of intervention depends on the size and location. The challenges in treatment lymphodepletion grade 3. And we should leave it alone if you don't have the necessary equipment for surgery. Okay, that's my presentation. Thank you.
Okay, thank you very much, Dr. Yu, for your interesting presentation about corneal diagnosis. And for treatment of surgical interventions by difficult and sometimes with brain 2 or brain 3 is very difficult to recover his vision and also cosmetic preservation. So, there's any question or comment for Dr. Yu? How about Dr. Thủy? I know you also have many patients during surgery in outpatient. So how about, can you comment